maybe. All right, we were talking about the organization, all right, and the anatomy of the sympathetic division. Okay, remember we had of the autonomic nervous system, you have the parasympathetic division, rest and digest, and you have the sympathetic division, the fight and flight. All right, and so we talked about the sympathetic splenic nerves. These are the ones that it's important that you understand this. They do not synapse in the sympathetic trunk. All right, so that means that that preganglionic neuron, remember in the motor aspect of the autonomic nervous system, you have two lower motor neurons. The preganglionic motor neuron and then the postganglionic motor neuron, also known as the ganglionic neuron. Okay? So in this case, the preganglionic neuron exits out of the spinal cord, okay, through the spinal nerve, enters into the sympathetic trunk, but does not synapse there. And it shoots right through the sympathetic trunk, and it exits anteriorly, okay? And then it's going to arrive at one of these guys. Remember those prevertebral ganglia? There's 3 of them, okay? And they were affiliated with branches off of the descending abdominal aorta. Okay, you had the celiac prevertebral ganglia, the superior mesenteric, and the inferior, okay? So it's here that this preganglionic sympathetic axon is going to come in contact with the postganglionic neuron, okay? In one of these 3, all right, prevertebral ganglia. So they're not far away from the spine. In fact, they're close to the vertebral column. They're right in front of it, okay? Because so is the descending abdominal aorta. It sits right in front of the vertebral column, okay? So it's still close. It's going to follow the rules for sympathetic divisions that the axons, the preganglionic neuron is short, and the postganglionic neurons are long when we're talking about the sympathetic divisions. Remember those characteristics, okay? But these will be found in the abdominal pelvic cavity. We talked about all these different, I'm not going to go through each of these again, but the celiac ganglia, superior mesenteric, you want to know, all right, what they're going to be supplying, okay? All right, but again, these are all going to be structures, all right, in, all right, the abdominal pelvic cavity, okay, with all those prevertebral ganglia. Because now we're going to talk about, there's 4 different pathways here. And we talked about Horner syndrome, remember this? Okay? Horner syndrome is when you lesion, all right, one of the cervical sympathetic trunk ganglia or T1. Okay, you'll get these following symptoms. You get drooping of the eyelid. You'll, the eyeball there, all right, is going to be constricted, okay, because we can no longer control the dilator muscle. Right? You have a lack of sweating because sweat glands are controlled solely through sympathetic innervation. Right? And then flushing, because again, blood vessel, we'll talk about this, blood vessel diameter is solely controlled by sympathetic innervation. So if you disengage that or knock it out, then you get vasodilation. More blood, more redness. Okay? All right, so now we're going to talk about the sympathetic pathways. This is new. Okay? And there's 4 of them, and we've already talked about one of them when we talked about the splenic nerves. Okay? So let's talk about, all right, how these axons, all right, are going to enter into the sympathetic trunk and then how they're going to exit the sympathetic trunk and go out to the effector organ. So there's 4 ways to do this. The first one is the spinal nerve pathway. All right, so what is this going to affect? Well, pretty much in the neck, torso, and the limbs. Well, that's pretty much most of your body except for your head. All right, so upper and lower extremities, your neck, and your torso. All right, so these are going to be the skin effectors. Well, what are those? All right, skin effectors are going to be blood vessels out there in the skin. All right, sweat glands, the erector pili muscles. All right, they give you the goosebumps. Okay, those are going to be the skin effectors. So here's what happens: the first neuron, the preganglionic neuron, okay, exits from the spinal cord. Okay, goes along the spinal nerve. Then it's going to enter into the sympathetic trunk via the white rami communicantes there. Remember, it's white because it's myelinated, right? It's myelinated. And then it's going to enter into the sympathetic trunk, and there it's going to synapse on the postganglionic or ganglionic neuron, all right, in the sympathetic trunk. Now, that postganglionic neuron is going to exit out of the sympathetic trunk through the gray rami communicans, or the gray ramus, right? And it's gray because it's unmyelinated, all right? Remember, the white rami are the on-ramps. They're going to bring the neurons into the sympathetic trunk, and the gray rami are the exit ramps. They're going to leave, okay? And this is important. So the postganglionic axon is going to exit the gray ramus at the same spinal level as the ganglion to which it's synapsed. And it's going to head back out to the spinal nerve. And eventually it's going to go out to the effector. So I'll show you a picture. It's really cool. Okay, so keep that in mind. All right, so this one here, when I say it's easy, it's simple in the fact that the preganglionic neuron enters into this sympathetic trunk, it synapses, and then the postganglionic neuron exits the sympathetic trunk at the same spinal level. Okay, so now I'm going to show you some options here. As long as you understand that, when I show you these three options, it's going to be simple. Okay, so here's what happens. Same story for each of these options in the beginning. Okay, so our preganglionic axon exits the spinal cord, all right, always along the anterior rootlets, joins up, enters into the spinal nerve, all right, and then it'll enter into the sympathetic trunk through the white rami communicantes, or white ramus. Okay, it's white because it's myelinated. Remember, all preganglionic neurons are going to be myelinated, so they're going to appear white. Okay, so it enters in. Now, here it's got three options. I didn't tell you this on the slide previously, okay, because I don't want to confuse you. It has three options, all right? First option is it can synapse here on the postganglionic neuron, and then you know the rule. The postganglionic neuron has to leave at the same level that it synapses. So the preganglionic comes in, synapses on the postganglionic, it exits on the same level and goes out. Okay, so nothing happens. This next option here shows us, okay, that preganglionic neuron, all right, same story, exits the spinal cord, enters in through the white ramus, and here, now it's not going to synapse. It's not. It's going to go up a level, or 2 levels, or 3 levels. It can go up 4 or 5, whatever, okay? It can ascend. So it ascends to its desired level, then it synapses on the postganglionic neuron. Once that happens, that postganglionic neuron has to leave at that level. It has to. Okay, that's our rule, all right? And if you don't believe me, go back to here, okay? Here it is. That postganglionic axon has to travel through the gray ramus at the same level as the ganglion there. The same level. Okay? So no matter what, it has to exit there. Once you synapse, you're leaving. You're getting kicked out. You got to go. All right? So now, our third option is, same story, preganglionic neuron, all right, exits the spinal cord, enters into the white ramus, and now in this case, it's going to go down a level, or 2 levels, or 3 levels, or whatever. But when it gets to that desired level, it will synapse, and once it synapses, that postganglionic neuron has to exit that same level and leave, and that's it. You guys follow me on that one? Okay? So it always, when we're talking about the spinal nerve pathway, you have 3 options, okay, for the preganglionic neuron. It can either enter into the sympathetic trunk, synapse immediately, then that postganglionic neuron will leave at the same level. So it all happens, that's what this picture here is showing us. This all happens on the same level. all right? Or that preganglionic neuron can enter in, and it can go up 1, 2, 3 levels, all right? But once it synapses, that postganglionic neuron leaves at whatever level it synapses at. Then the third option is, all right, the preganglionic neuron enters in to the sympathetic trunk, okay, and then it descends. And then it descends to the desired level, synapses on the postganglionic neuron, and that postganglionic neuron has to leave at that level. Wherever the synapse occurs, all right, the postganglionic neuron leaves at that level. So if the synapse occurs at T12, it leaves at T12. If the synapse occurs at T4, it leaves at T4. Okay, it has to go. Okay, so that's the spinal nerve pathway. Okay, so now we've got our postganglionic sympathetic nerve pathway. Now, first we have to see where this is occurring here. All right, so the effector organs are going to be the internal organs of your chest and neck. So that is going to be like the trachea, all right, any of the smooth muscle glands in there, heart, esophagus, all that. Then all of our skin effectors of the head and neck. Well, thank goodness. All right, because with the spinal nerve pathway, we excluded the head. So now we're including our skin effectors for the head and parts of the neck that the spinal nerves didn't contact. And then finally, eyelid and dilator pupillae muscles. Okay? So we deal with the eye. All right, now, here's the story. The preganglionic neuron exits the spinal cord. Now, in this case, it's going to synapse in the sympathetic trunk ganglion. Okay? But here's something new. The postganglionic axon does not leave through the gray ramus. Okay, normally that's what we learned, right? With the spinal nerve pathway, it was always leading through the gray ramus, always leading. So in this case, it's going to go right out of the sympathetic trunk to the effector organ. Okay, so this was different. All right, with the spinal nerve pathway, we saw the postganglionic neuron leading through the gray ramus, entering back into the spinal nerve, and then going out to wherever. All right, in this situation, okay, preganglionic does the same thing. It enters in. It's going to synapse onto the postganglionic, but now the postganglionic neuron does not leave through the gray ramus. It goes directly to the effector. All right? So I'll show you a cool picture here after I take a drink. Okay, so I love pictures, especially for this portion of the chapter. Okay, so here you can see, here's our preganglionic neuron, same story. Okay, it's going to enter into the sympathetic trunk. Okay, and again, it can ascend a level, all right, it can descend a level, or it can synapse directly on that same level. Okay, so once it synapses, though, that postganglionic neuron is not going to leave through the gray ramus. And any of these, no. It's going to come directly out, all right, of that sympathetic ganglion, and it's going to head to the effector organ. Okay? That's one that's different. All right, this is called the postganglionic sympathetic nerve pathway. Okay, so that's the second of the 4 ways or pathways that we're going to learn about. Well, this third one here, you've already learned about somewhat, the splenic nerve pathway. Okay? This is the one that we were talking about, those paravertebral ganglia here, all right, the celiac, the superior mesenteric, and the inferior mesenteric ganglia. All right, so now we're just going to put it down into words and show you some pictures here, make it a little bit easier. Okay, so now our effectors for the splenic nerve pathway are going to be found in the abdominal pelvic cavity. So we're going to affect abdominal and pelvic organs. Okay, so in this scenario, that preganglionic axon is going to go directly through the sympathetic trunk, but it's not going to synapse. It's not going to synapse. We knew that before. We talked about this last class, okay? And it's going to head directly to the prevertebral ganglia. So it's either going to go to the celiac ganglia, the superior mesenteric ganglia, or the inferior mesenteric ganglia. That's where it'll synapse. And then from there, the postganglionic neurons will go out to the effector organs out there in the abdomen and out there in the pelvis. Okay? So again, splenic nerves do not synapse in the sympathetic chain or the sympathetic trunk. They go right through it. They come into it, don't synapse with anything, and they exit. All right? And their ganglia are going to be located in one of those three areas that I mentioned, the celiac, superior mesenteric, or the inferior mesenteric ganglia. So that's what we're going to see here in this picture. Okay, here you can see, all right, our splenic nerve pathway here. So our prevertebral ganglia, or excuse me, neuron exits out, same story. All right, it's going to enter into the sympathetic trunk, all right, via the white ramus, like normal. That hasn't changed. But now, in this case, all right, it's going to pass right through. Now, again, we can see the same story. It can pass right through at the same level that it enters in on. It can go down a level, or it can go up. Okay? Just it varies. It varies. All right? So point being is, it's going to pass right through without synapsing, and it's going to go find that prevertebral ganglia. Okay? The celiac, superior mesenteric, or inferior mesenteric ganglia. It'll synapse there. Then the postganglionic neuron, all right, is going to travel to the effector organ. Okay. This next one is easy. All right? And it's very special. Okay? This last one is the adrenal medulla pathway. Well, if you remember, all right, the adrenal medulla is the central portion of the adrenal gland. There's only two hormones that are made there, and that's norepinephrine and epinephrine, okay? Otherwise known as adrenaline, okay? So in this scenario, we are going to stimulate the cells in the medulla of the adrenal gland, okay? That's that central region here, okay? So this is what I love about this one, okay? This pathway, we're only going to utilize one neuron. That's awesome. Remember, synapses slow messages down, right? Mainly the chemical synapses do, because we got to convert an electrical signal into a chemical one and then back into an electrical one, all right, unless it's an effector organ. And in some cases with the effector organs, like with muscles, we have to have our muscle action potential, okay? Well, in this situation, we're just going to deal with this one neuron, the preganglionic neuron, okay? It's going to exit the spinal cord, excuse me, all right? It's going to, again, go right through the sympathetic trunk, all right? It's going to go right through the prevertebral ganglia, no synapsing in both. Ain't got time for that. No time. We got to go. And we're going to go right to, all right, the adrenal medulla cells. Those are called neurosecretory cells. And we're going to release our epinephrine and our norepinephrine. Why? Fight or flight. Okay? Epinephrine, norepinephrine have amazing effects on certain viscera, right? Especially the heart. Right? It'll increase the contractility of the heart. The force of contraction will speed up the heart rate so you can get more blood pumping. Right? Get those muscles going. All right? Get the heck out of there if you've got to run. Okay? So this will actually prolong that sympathetic fight or flight response when you're exercising or if you're in an emergency situation, all right, stressful scenario. So we're only going to deal with one single neuron here. Check out the picture. All right, here you can see it. All right, there's that preganglionic axon exiting from the spinal cord here. Then again, same story, enters into the sympathetic trunk, exits without synapsing, all right, travels all the way through the splenic nerve, exits the prevertebral ganglia, again, no synapsing, go directly to the adrenal medulla, collect $1,000, secrete epinephrine, norepinephrine, game over. Look at that. No, one single neuron in our chain. It's not even a chain, all right, just one thing, that's it. Okay? Does it make sense? I think it does. No synapses. Speed of the action potential will be that much faster. All right? It just makes sense. All right, so that is the fourth pathway. Okay? Just be familiar with them. I think the hardest part when dealing with these pathways is keeping preganglionic neurons and postganglionic neurons straight in your head. And then it doesn't help when we start to throw in extra nerve names like the splenic nerves, you know? I mean, then prevertebral ganglia, like where are those at again? All right, so again, just review that. Take your time with it. Because now I'm going to switch gears and talk about some really cool stuff. Not that this stuff isn't cool, but I really want to get into autonomic tone. Okay, and this is where we're going to start to talk about, because this helps, this information that I'm going to be discussing with you is going to be very helpful and important when you take 211 and you start getting into the different systems like the digestive system, all right, well, even the endocrine system a little bit, but you know, circulatory system, all these systems next semester or whenever you take 211, it's going to be very helpful, okay? So autonomic tone, this is an important term here, all right, is when you're going to see, all right, the continuous release of neurotransmitter. Okay, remember, we learned the different neurotransmitters that are involved in the autonomic nervous system, acetylcholine and norepinephrine. Okay, those are going to be our neurotransmitters, but now you probably just didn't think that some of these neurons are just going to be continually releasing the neurotransmitter. Okay? And when it does this, all right, we call that autonomic tone. All right? So you have to understand something here. We're going to talk about some of the concepts of the autonomic nervous system. And a lot of the structures in the autonomic nervous system are innervated by both the parasympathetic nervous system division and the sympathetic nervous system division. Okay, a lot of them, but not all of them. Okay, and I'll tell you which ones to keep an eye on. That's why we say most effectors are innervated by both divisions. All right, but not all. Okay. So when only one is innervated, all right, by one division, okay. For example, like our blood vessels, okay, they're innervated solely by the sympathetic nervous system, and when we give it a term, okay, we call it vasomotor tone. So the sympathetic division is constantly releasing its neurotransmitter onto the end organ, and in this case, our end organ is the blood vessel. So it's going to be continually releasing, all right, the neurotransmitter onto the blood vessels, causing the blood vessels to be in a partially constricted state. Okay? So the fact that these blood vessels are in a partially constricted state gives us two options. Okay? One option is we can constrict them more. We can make them smaller. The other option is we can constrict them less and make them bigger. Okay? So those terms are called vasoconstriction and vasodilation. So the fact, if we didn't have this vasomotor tone, all right, our blood vessels would be constantly relaxed unless one of the divisions was acting upon them. All right? And so we would be, how did I do that? We would be limited, all right, to how much dilation we could have. But the fact that we had that vasomotor tone and the fact that these blood vessels are partially constricted gives us more options. We can constrict more, we can constrict them less. All right? And depending on what the sympathetic nervous system does will determine the effector outcome. Meaning, if we increase the activity of the sympathetic nervous system on the blood vessel, all right, what will happen is we'll constrict the blood vessel more. Okay? It's like turning up the dial, turning up the heats. You want to boil the water faster? Turn the heat up more. Okay? So now, if we decrease the sympathetic activity, we're going to turn the dial down, then that blood vessel can vasodilate. So we can make it bigger. So this is what happens. Okay? So normally with vasomotor tone, this is what we normally will have. If we turn up our sympathetic activity, it will vasoconstrict, and we make it smaller. All right, if we lighten up on the sympathetic activity, we make it bigger. Y'all see that? Vasomotor tone. Okay, that's going to be one division. Okay? We see vagal tone when we talk about the heart rate. Okay? Only the parasympathetic nervous system can decrease the heart rate. The sympathetic nervous system can increase the heart rate, but it can also increase the force of contraction, or it can increase the contractility of the heart. I'm not going to talk about that here because chapter 19, you guys get to talk about it all the time. All right, so dual innervation. This is what I was telling you about. When both divisions, all right, are going to innervate, all right, an organ. Okay? So in this situation, when we say dual innervation, the organ receives input from both the parasympathetic and the sympathetic divisions there. Okay? So we have two possibilities. All right? The divisions can have antagonistic effects, okay, which means opposite. Okay? Where one will increase something, the other one will decrease something. Okay? Or they can have cooperative effects, which means that both the divisions are going to work towards a common goal. Okay? I don't want to spoil what that is. We'll talk about it here in a moment. So when we talk about the antagonistic effects, all right, opposition is going to be involved here. Heart rate's a perfect example. Okay? Whereas when we're stimulating the parasympathetic nervous system, we slow the heart down. Okay? When we stimulate the sympathetic nervous system, we increase the heart rate. Okay? And that's the nice thing. We briefly talked about that, but when we talk about cardiac cells here, they have these two types of receptors, cholinergic and adrenergic. And depending on which one of those receptors that are stimulating, all right, will determine the outcome, all right, of the effect on heart rate. Okay? Questions about anything so far? This mask is making me mad. All right, that's dual innervation. Did you like that? I got some more antagonistic effects here coming up. You ready? Let's talk about food, the digestive tract. Okay? Parasympathetic nervous system, remember, is rest and digest. So the parasympathetic nervous system, in this case, is going to really stimulate, all right, the digestive tract. It's going to increase motility, all right, so we can move food around more, okay? Slosh around like a cement mixer does when it's mixing cement. Increase secretions for digestive enzyme activity. All right, whereas the sympathetic nervous system is going to shut that down. It decreases the motility. All right, which makes sense. All right, when you're exercising, if you're going to run a marathon, you really don't need your digestive system at full capacity. Okay? You don't need to start having to go to the bathroom when you're running. That's going to be a problem for you. All right? And so when we start to engage in activities of exercise or emergency-like, right, we start to kind of slow down or turn off, I won't say completely off, but start to decrease the activity of the digestive system, okay? All right, the eye. We talked about this a little bit last week. I can't say last week was spring break, sorry. 2 weeks ago, last class, all right, in which we see that the autonomic nervous system, all right, has that dual innervation of the pupil size in the iris. And I told you that when you stimulate the sympathetic nervous system, the pupil dilates, it gets bigger, okay? And that's because you are activating the pupillary dilator muscle, okay? And then when the parasympathetic division takes over, you're going to constrict the pupil, right? And that is because you are going to be stimulating the pupillary constrictor muscles, okay? So again, these are another example, all right, of yes, dual innervation, but this is antagonistic effects, opposite. They oppose one another. All right, so the other type of effect you can have is the cooperative effect. And we'll see that during coitus or sexual functions, okay? And so both of these divisions, all right, will have different effects, yes, but the overall response is, or the eventual outcome is what these different effects are going to play a role in, okay? So when we talk about, we learned this in medical school when we were talking about male sexual function, all right? About sustaining an erection and then having an ejaculation. We called it point and shoot. All right? Point, meaning parasympathetic nervous system is going to stimulate and sustain an erection for the male. Shoot, all right, is going to be the sympathetic nervous system is going to actually achieve ejaculation. Both are needed, all right, for sexual intercourse. Okay? Okay? So you can see how yes, they're different. Okay, one is for an erection, the other one is for ejaculation, but the overall outcome and response is the desired effect. All right, so we're going to see. So that's how I remembered it from school. All right, parasympathetic is the pointing, the erection, and the sympathetic is the ejaculation or the shooting. All right, so that's cooperative effects. Questions so far? No? Okay. All right, so now we're going to talk about, all right, one division. Again, it always seems like we're going to the sympathetic nervous system, all right, but we're going to see, and again, I know we keep talking about the blood vessels here, all right, but we can see how just one system can have opposing effects, right? We don't need dual innervation in this situation. And for a long time, I'm going to be honest, before I went to medical school, I used to think that blood vessel constriction and dilation was a dual innervation. I used to think there was a parasympathetic component to that. All right, and it wasn't until last night where I learned it was different. No, I'm just kidding. All right, but I'm just saying, I could see how people would think that. All right, because of that dual innervation. But again, in this case, it all depends for our blood vessel diameter. It all depends on the sympathetic activity, okay? So if we turn the dial up on the sympathetic activity, all right, we're going to release more of that neurotransmitter, okay? And we're going to get further constriction, okay? And the opposite will happen if we turn the dial down on that sympathetic activity. We'll release less neurotransmitter, all right, to the point where we'll have more vasodilation. Okay? All right, we talked about sweat glands. Okay, sweat glands are only controlled by the sympathetic nervous system. All right, when we're dealing with the sweat glands found in the trunk. Rectopili muscles, I mentioned that before. Okay, it's that smooth muscle that attaches onto the hair follicle, giving you goosebumps. And then also, we just talked about that final pathway here when we were talking about the neurosecretory cells. All sympathetic innervation only. No dual innervation there. Okay. Has anyone ever heard of Reynolds? Anyone here? Reynolds is every person, I won't say every person, that's an exaggeration. But a lot of people, when they say, oh, I have Reynolds, they'll usually talk about Reynolds because they get cold hands. All right? And there's Reynolds phenomena, and then there's Reynolds disease. All right? Reynolds syndrome, all right, is something a little bit different. Like Reynolds disease is when you literally have blue hands or blue fingertips because of a decrease in blood flow to the distal portions of your fingertips. Here we're dealing with the Reynolds syndrome here. Again, we are seeing vasoconstriction, okay, to, all right, the distal regions of your digits. So you will see, all right, a decrease amount of coloring, all right, and I don't have the picture here, but you can actually see, I do believe in your textbook there's a picture of somebody that has Reynolds, and their fingertips are white, all right, not like white like a piece of paper, but really, really tan like these tabletops, and the rest of their hand is red because they've decreased the amount of blood flow to that area there, all right? But this has to do with the sympathetic nervous system. Okay, it's a localized issue, all right, in the distal portions of those fingertips in which those blood vessels have constricted. All right, and as we know, when you get vasoconstriction, we're getting increased sympathetic nerve activity there. Okay, and because of that, we're decreasing the flow of blood, all right, which will then decrease the coloration of those fingertips. Obviously, we'll see pain depending on how long that lasts, and unfortunately, I'm sorry, but this happens more often in women than it does men. All right, so it's just an exaggerated response, all right, to some sort of situation. All right. Some stimulus. Temperature is usually the main cause for that. Right? We could also have a limbic system involvement there when we're dealing with emotional stress too. Okay? Because emotional stress stimulates the sympathetic nervous system. That's how it is. Fight or flight, people. Oh, I love autonomic reflexes. This I get the opportunity to teach to you wonderful folks because I want to. We're killing it, by the way, on time-wise. We're just killing it. But I want to take the time because this is almost like an introduction to what you're going to be dealing with 75% of the material in 211. Okay? Has to do with autonomic reflexes. Okay? Or also known as visceral reflexes. All right? What organs do. Okay? Now, you probably remember this term here, the reflex arc. We all know that reflexes are pre-programmed responses to a specific stimulus, all right? And it comes about through the reflex arc. That's why this, if you know this, like if you get this, okay, I can guarantee you that a lot of the information that you come across when you do systems, all right, in later biology classes are going to be a breeze. Like if you can understand the reflex arc, then you're going to be good to go, okay? So let's review what the reflex arc is. It all starts off with a stimulus, okay, that is picked up by or monitored by a receptor, okay? So we have a receptor, and that receptor has to be specific, all right, to a specific stimulus. For example, sight. The receptors that we use for sight are called photoreceptors. And they operate on light, okay? Well, guess what? You can't see sound waves, right? So sound waves, that stimulus of sound, cannot trigger your photoreceptors to operate, and vice versa. Light can't affect, all right, your hair cells in your ear. Okay, I can shine a really bright light into your ear. You're not going to hear a thing. Okay, you might hear the buzzing from the light bulb or whatever, but that's point being is it's got to be receptor specific for that stimulus. Okay, so once that receptor picks up on that stimulus, it's going to send sensory input to our control center, which is the central nervous system, spinal cord, or brain. If it goes to the spinal cord, it's a spinal reflex. If it goes to the brain, it's cranial reflex. Okay? So it goes to our control center. Okay? That control center there is going to process that information, and then it's going to determine how it's going to respond. Okay? And in doing so, it's going to send that motor outputs or that motor information utilizing our motor neuron. And that's going to exit out of the central nervous system and go to our effector organ. So what's our effector organs when we're dealing with autonomic reflexes? All right, check it out. Here are the effector organs: cardiac muscle, smooth muscle, and glands. Okay, I'm telling you, if you understand this slide, you're going to be sitting in 211, you're going to be loving life. And you're like, I get it. Get it. You'll figure out how the heart rate increases because of a certain stimulus. You're going to figure out how that when you put food into your mouth, your stomach acid secretion increases. Pepsinogen, which is an enzyme that helps to digest proteins, those increase in your stomach as you're chewing on food. It's all based on reflexes. How when your stomach empties food from the small intestine, all right, your large intestine has what we call a mass movement, and it shoots a lot of the food product in your large intestine, further distal through the large intestine towards the rectum, so you can go to the bathroom later on, clearing the way. Right? These are all reflexive responses. These are autonomic reflexes, and it's really important that you know that. All right, we're missing an effector here. What effector are we missing? No, skeletal muscle. Skeletal muscle. But guess what? Skeletal muscle is not part of the autonomic reflexes. Remember, because that's part of the somatic nervous system. Okay. So skeletal muscle won't be found here. All right? These are autonomic reflexes. They're visceral reflexes. Okay, so I'm telling you this right here. Know this reflex arc. Because when you're learning this stuff next semester, if you're unfortunate enough to have me again, I'll beat it into you. Okay? I was going to drink that hand sanitizer. What the heck's wrong with it? All right. So let's talk about the cardiovascular reflex, for example. You're going to get into this in much more detail. I'm going to do 2 reflexes with you, and then we'll take a break because we'll be done. Okay? So the cardiovascular reflex, this is blood pressure. Right? I talked about it a little bit when I was going over the, in chapter 13, we were talking about the hypothalamus. Okay? The cardiovascular reflex for blood pressure, all right, is going to start off, and if you look at this slide here and read through it, we're going to start off with our stimulus. So our stimulus in this case is going to be, for example, an increase in blood, let's just say. Okay? So your blood pressure increases. So what happens when your blood pressure increases? It puts more stretch on the blood vessels, on the walls of those blood vessels. So you have these specialized receptors in the walls called baroreceptors. Okay, we'll go into a little bit more in chapter 16 because we're going to go through a bunch of different receptors. We'll talk about that. But baroreceptors, their job is to respond to stretch. Okay, you have them in your stomach. When your stomach starts to fill up, all right, it will cause a sensory input going up to your digestive centers. Well, in your blood vessels, you get an increase in blood pressure. It puts more stretch on the vessel walls, and so those baroreceptors get stimulated, and they send that information via sensory neurons to the control center in your medulla oblongata. Okay, the control center is called the cardiac center. Okay. And it is going to then be processed in the medulla oblongata, and your cardiac center will now decide how it wants to respond. Well, if blood pressure is high, we got to decrease it. So guess what I'm going to do? I'm going to inhibit the sympathetic nervous system. Okay, because what does the sympathetic nervous system do? The sympathetic nervous system, we just got done with it. All right, we were talking about how it affects blood vessels, right? If we inhibit the sympathetic nervous system, then it's going to release less neurotransmitter, causing some vasodilation of the blood vessels. But what else affects blood pressure? Okay, the heart does. So the sympathetic nervous system increases the heart rate. So if we inhibit that, all right, we're not going to be able to increase the heart rate. What we can do is decrease the heart rate. How do we do that? We activate the parasympathetic nervous system, specifically the vagus nerve, cranial nerve 10. All right? So we activate the parasympathetic nervous system, and that will decrease, all right, what we call cardiac output. Cardiac output, all right, is going to be determined by your stroke volume, which is the amount of blood ejected from the heart per heartbeat, and the heart rate. How many times the heart is beating, okay, in a minute. All right, you get to learn all that stuff later on. But for right now, we inhibit the sympathetic nervous system, all right, and activate the parasympathetic nervous system, and that will slow the heart down. Less blood gets pumped out of the heart, all right, that slows the heart, and that decreases the amount of blood that's ejected out, and the overall effect is we decrease the blood pressure. We took away the stimulus. All right, remember, our stimulus was increased blood pressure. Increased blood pressure puts more stretch on the blood vessel walls, stimulating the baroreceptors. So now our response was going to be in the opposite direction, like a negative feedback loop. Okay? So that negative feedback loop is going to then decrease, our overall outcome will be to decrease the blood pressure. How do we feel about that? Not too bad? All right. You're going to get in much more detail later on. All right. So let's finish up here and talk about, all right, two common autonomic reflexes. One of defecation, the other one of urination. Okay? Similar, all right, storylines. Okay? We're going to start with the stimulus, then a receptor is going to monitor the stimulus. All right, and then we're going to send that sensory information to the control center, which will then figure out what the response is going to be, and then we're going to carry out the response through the motor output. Okay? So in this situation with defecation, all right, for our gastrointestinal reflex, we're going to see in the rectum, okay, that's that final area of our digestive system right before the anus, all right, as we add more fecal material to the rectum, that is going to increase the stretch of the walls of the rectum. Well, guess what sits in those walls? Baroreceptors. Okay, stretch receptors. As we increase the amount of material in there, we will increase the stretch, so that information is going to be sent to the spinal cord. The spinal cord is still part of the central nervous system. It's our control center. Okay? So this reflex is a spinal reflex. Doesn't go up to the brain. Okay? So the spinal cord then responds by stimulating the motor neurons, all right, that go to the rectum, and it's going to, one, cause the internal anal sphincter to relax, while at the same time, it's going to stimulate the smooth muscle in the walls of the rectum to contract. And that is going to help to push the fecal material out. Now, there's one other thing that's not listed in this reflex, and it's not really part of the reflex, all right? But there's the part of the reflex in which we all right, become a part of, a conscious part of, is like when you were actually physically, consciously trying to go to the bathroom, okay? And that involves the external anal sphincter, okay? And that will involve, all right, your cerebral cortex, your motor cortex. All right, this is where you are going to have to relax the external anal sphincter because it's made of skeletal muscle, so you actually have control over that. And in some cases, you will have to invoke what's called the Valsalva maneuver. Is anyone familiar with the Valsalva maneuver? When you increase the intra-abdominal pressure, you increase the pressure by trying to exhale against a closed glottis. That's the definition of it. What's the glottis? The glottis is the opening in your larynx, your voice box there. So you'll close that down, and as you start to increase your intra-abdominal pressure, it's almost like, well, we all know what to do. It's hard for me to explain, but you all know what you do when you're on the toilet, all right? That's what that is, all right? You're actually doing the Valsalva maneuver, all right? You're increasing that pressure. You're trying to push to help move the fecal material out of your body, okay? That's not part of the autonomic reflex, though. Okay, that's just part of defecating. All right, the micturition reflex, urination, similar type of scenario. Okay, I'll even show it to you in a picture here. Okay, we're going to deal with the bladder. All right, and as it fills with urine, the more urine that enters into the bladder through the ureters, right, it will put more of a stretch on the bladder walls. Okay, and as the volume increases, all right, you'll get more of that urge to go to the bathroom. Okay, so that sensory information again gets sent to the spinal cord. So we're dealing with the spinal reflex. All right, and what will happen is then the motor output will descend down from the spinal cord, all right, to the muscles, all right, the smooth muscles in the wall of the bladder, and that will start to contract. Meanwhile, again, we have two sphincters that we're dealing with in the bladder, and the internal urinary sphincter, all right, or urethral sphincter, will relax. But don't forget, there's a second sphincter there. That's the external urethral sphincter, and that's under our voluntary control. All right, and this is what you learn how to control during potty training. Okay, so I'll show you a picture here. Last slide. All right, so here you can see, Okay, urine comes from the kidneys via the ureters down into the bladder. All right, it starts to fill the bladder. The more it fills, the more volume of urine there, the more stretch is placed on the walls. So the stretch from the volume of urine, all right, is our stimulus. The baroreceptors will transmit that information here to the spinal cord. All right, the spinal cord will then what's my brain? Will examine the information, integrate the information, process that information, and determine, all right, what the outcome is going to be. And it does so by stimulating the motor neuron, all right, which is going to travel down here, all right, to the bladder and innervate the smooth muscle in the walls of the bladder to start to contract. While at the same time, it's going to relax, okay, the internal urethral sphincter, okay, to relax so urine can start to travel out. But the last part of this urination or micturition process involves the external urethral sphincter down here, and that's in the levator ani muscles. Those are the muscles that make up the floor of your pelvis. And so you relax those, right, and then urine can leave. So now you know, all right, some of the autonomic reflexes. You see the pattern there? All right, starts off with a stimulus. All right, receptors pick up on that stimulus. Control center integrates and then processes that information and then determines whatever the actual resulting action is going to be through motor output through the effectors. Okay, and you're going to see a lot of that process and a lot of that what's the word I want to use? Repetition or I'm having a hard time tonight trying to figure out words, but you're going to see a cycle or pattern, okay, with these reflexes. And this, if you understand this now, I'm telling you, it'll help you when you're learning the other systems of the body. Any questions for me? No? Okay. We're done a little bit early, so let's take a break, 15-minute break. We'll come back. Yes, ma'am. Yeah, of course, of course. I'm going to stop recording now.